Good afternoon, everyone. This is Sanjay Jha. The host of the moderator for this session was supposed to be Mr. Anjan Bose, but he's having some technical difficulty and he's not able to join. So till that time he joins, I'll be working on his behalf. In this session, we have lots of eminent speakers, apart from Mr. Anjan Bose, who had been former founding Secretary General of NATHEALTH and former President of Philips Healthcare and Consumer Health India and South Asia. We have Dr. Mahajan, who is founder and chief radiologist of Mahajan Imaging, and Padma Shri Awardee 2002. We have Mr. Rohit Sathe. Rohit Sathe is Vice President Systems for Indian subcontinent of Philips India. We also have Mr. Yagnik. Mr. Kailash Siemens engineers in India for 20 years. Since last 4 years as a senior vice president. And me, Sanjay, I am currently director of Collateral medical practice. We also have Mr. Ashutosh Banerjee. He's based out of the US, so timing did not work out for him, but we do have a message from him for this time. Request to start with Mr. Ashutosh Banerjee's video, please.
Hello, everyone. My name is Ashutosh Banerjee. I am the General Manager for Cardiology Solutions for GE Healthcare. I am based in Milwaukee, near Chicago, in the US, and hence I apologize I cannot be there in person to be in this panel because the timing of the panel didn't really work out with the timing here in the US. But I really appreciate the opportunity to speak with all of you and be a part of this eminent panel with such an esteemed panel members out here. I know quite a few of you, and I think I may have met a few of you also. Sanjay, for sure, he and I have worked together in one of our companies in our career. Anjan Bose, I have known of you, and very, very nice to be in the same panel as you, as you're moderating. Rohit and Kailash, I'm sure we have met somewhere on the field because our companies share maybe a frenemy kind of a relationship. And Dr. Mahajan, it's very nice to be in the same panel as you. So, I appreciate the opportunity to speak here, but because I'm not live out there, I thought I would just take a few minutes to talk about some of the topics that are there on the panel and maybe give my opinions on that. So hopefully, Anjan, it can help you in the panel discussion and you could weave it in somehow. So we talk about post-COVID and what's going to happen in the medtech industry post-COVID. COVID has been a really big change, not just to the medtech industry or the healthcare industry, but to our way of life for sure. An example of this is me sitting here in my office, all decked up, but nowhere to go. We have all been working from home, and the case numbers in the US and India are continue to rise. So that's an example of what has changed. We almost talk about pre-COVID and post-COVID. So in that vein, post-COVID, a lot of things are going to change, and we see that happening today in the medtech industry. One of the biggest changes is around telemedicine. And I'm sure everybody would agree with me when we see that telemedicine and the innovations around telemedicine will be a part of our dialogue and our discourse going forward, I think for a long time to come. Maybe one of the biggest accelerators for telemedicine is going to be COVID. And the reason for that is pretty obvious. People do not really want to get together in large gatherings. People are afraid to go to hospitals. And that's what will prompt a lot of these, the offerings in the telemedicine space to be accelerated and many more offerings to come in here. From the devices point of view, I would say that infection prevention, especially in acute care areas, where we need to be really cognizant of how we make sure that our devices facilitate infection prevention and the processes around those. Wireless and making sure they are integrated. We don't really want to touch things anymore. We try to avoid them, right? So how do you make things wireless, touch-free, gesture control, things like that? And how do you enable remote work? How do you enable consultation from a remote point of view? How do you enable still the same kind of empathy that a healthcare provider can provide to the physician or to the patient, but do that from a remote way? Can our devices do that? So those will be some of the questions that we will have to face and we'll have to talk about in the medtech industry for a long time, I imagine. The second thing, and this is a very interesting topic that I saw in the panel notes. So about compliance and innovation. How do we balance compliance and innovation? I'm always intrigued by this question because, in my opinion, compliance is a must because we are in the medical industry. There is no going away from compliance. And in fact, in my experience, I have not seen compliance hinder innovation at all. In fact, if we plan for compliance, then innovation comes naturally, and innovation will be in the right direction. It will not be in a direction that may sometime hurt the patient, but it will be in a direction that will really help the outcomes for a patient. So if we stay outcome focused and we plan for compliance and treat it not as a risk or a hindrance but necessity, I think innovation will find its way. And that's what we have been doing at our work, and I think we have been pretty successful there. Lastly, just one thing around new age technologies. So we have been talking about machine learning, AI, ML, DNN, CNN, you name the acronym that's there. We have also been talking about IoT and things like virtual reality or augmented reality. I think which one of these technologies help us accelerate will depend on a few things. First of all, I think what is the outcome and what is the problem we are trying to solve? So in post-COVID times, like I was saying before, the outcome of enabling remote connect and enabling remote care is going to drive a lot of technologies. Being remote but still training the people, being remote but still making sure patients are taken care of. Those are going to accelerate a few technologies. So virtual reality comes in mind because for training medtech salespeople, that might be a very good tool. For servicing equipment, that might be a very good tool as well. How do you train service people and maybe even use that as an application when you are doing the actual service to help the biomedical on the site do the service while the trained engineer is helping through VR. Maybe that's something that can be there. So that's one thought. If you look at machine learning, now there are two things that are happening. One, there has always been a lack of availability of experts around the world. There are never enough cardiologists, enough radiologists, enough specialists to help sort out the problems that are there and take care of patients. So there is always a need to have interpretation and algorithms that help drive automated treatment. And Dr. Mahajan himself, I know there is a lot of work on machine learning that is happening in that area in radiology. In cardiology also, there is a lot of work happening. And in cardiology, machine learning is more focused on a workflow to see how patients are progressing or regressing. And that's where I think machine learning will really add value. How do we automate the interpretation, and how do we help a physician get some expert opinions and get help for a physician, support a physician versus take over a physician? That I think is going to be the balance that we'll have to drive in machine learning. If you look at IoT by itself is an interesting technology, but if you marry that with the fact that you have to now take care of patients at home, then IoT is a very important part of that discussion, because you need to have a lot of devices connected through a hub and talking back to the central station or the central hub, and to make sure that you can get data from the patient to the hub to make meaning out of that. So that will be, again, a very important discussion, but the focus has to be on outcomes, and that will drive a lot of innovation in the industry. So again, thank you for giving me this opportunity. Hope these remarks were helpful, and have a great discussion, and I look forward to seeing a recording of this. Thank you, everybody. Bye-bye.
Thanks, Ashutosh. That was wonderful. You talked about telemedicine, infection prevention, remote consultation, compliance. Well, and I'm pretty sure that our panel is going to talk about all of these now. Why personally I feel is physical infrastructure has been one area which is going to become less and less important. Uh, we have aggregators, we have telemedicine, who are enablers to that system. So, to the panelists, I'll start with it's medical innovation. So, Dr. Mahajan, what are your thoughts on what are the new transformational innovations driving the way forward for the medtech industry post COVID-19?
See, I think COVID-19 has really given a new opportunity to the medtech industry to innovate, to do new things, and also to do them very quickly without actually sacrificing quality. Because, as you very rightly said, in the medical industry, healthcare industry, we cannot take any chances. So, if you take only India, and if you look at what has happened in terms of the testing, let's just take one small piece testing for COVID-19. When we started in February, March, possibly in the entire country, we could do only about 1,000 tests per day of RT-PCR for COVID testing, which is the gold standard test. Today, consistently, at least since the last 2-3 weeks, we are doing over 1.1 million tests a day. So you can see what a transformation it has been. And this has been brought about by not just the diagnostic providers. It has been brought about by the medtech industry, which actually went to work very fast. The moment the genome sequencing was done, people were running and trying to build tests to be able to diagnose COVID-19. And for RT-PCR today, we are actually exporting. There is, despite doing 1.1 million tests a day, our capacity has for manufacture has gone up so much that they are exporting it. And at the same time, this could have only happened if the providers, the diagnostic centers, the diagnostic chains had kept pace and had also built up scale over time. And you see the numbers that I'm saying, that's something which probably only the US is able to reach this number. And this is not just RT-PCR alone. We also have the rapid antigen tests, which may not be as good, but yet is a point of care test, again, which has been now getting manufactured in India. This is a South Korean company which is manufacturing in India. And actually, there are 16 more companies which are knocking the doors of ICMR, and they are in various phases of getting permission to come in for rapid antigen tests. All this in the space of 6 months.
Correct.
So really, where things have gone down very badly because of the pandemic, there has also been an opportunity, which I think our entrepreneurs, and I'm just talking of testing. I'm not talking of the ventilators. I'm not talking of PPEs. Today, PPEs, India used to manufacture zilch,
Yeah.
hardly anything. Today, it's a 7,500 crore industry. And again, we have overcapacity in the country. The N95 mask, which was not available, not in India, not in the world. I mean, you couldn't get it in the US even. And when you got it, it cost you 400, 500 rupees a piece. Today, believe you me, there is so much glut. That same N95 mask you can get for 20 rupees,
Yeah.
which is accredited, which is built by the same machines where it's being built in the US or China or in Europe. So, and again, because of the glut, now these people are running after the government, and that's where I take a little, exception to how the government response has been. They are not being allowed to export even the PPE kits and the masks, and this may actually kill the industry. There is a demand abroad, and we are holding them back. Only recently these people have been given permission that a few samples they can send abroad. But I think we need to work very fast because we don't have any shortage anymore. And again, this is the government, both the health ministry, the textiles ministry, and our entrepreneurs here who have got together. In Gurgaon, the export industry for garments is now also manufacturing all of this and of the highest quality. So I would say COVID times have helped innovation. They have helped us venture into fields. We are today the second largest manufacturer of PPEs in the world after China. So that's tremendous. And we'll talk more about things as we go forward. Thank you.
I can add some there, Sanjay.
Yes, completely agree with you. So yes, Rohit, please.
So what I wanted to add to that, Dr. Mahajan, I think you brought an important point that said that there's just innovation of new products. So from having no manufacturing of PPE, you suddenly have people manufacturing, and that too in such huge quantities. It's suddenly a 7,200 crore industry. That's huge. I mean, that is what a crisis can force you into. But I think what it has also done, and I'm taking maybe a step back, is it has sped the pace of innovation. So let me give you an example. Something like an EICU, something like remote diagnosis, was something that we were trying to push, right? I mean, the industry was trying to say, hey, listen, this is more cost effective. This is more accurate. This can take care of the lack of experts in, let's say, tier 2 and tier 3 cities. And that was something that, everybody turned a deaf ear to. Well, let me not say everybody, that's melodrama, but most people did not listen to that, okay? And from that extreme, we've now gone to a place where people want that. They actively want remote connectivity, remote diagnosis, remote treatment. In fact, in our company, even the customer service aspect, we have about 75% of our machines now being diagnosed remotely and fixed remotely, which means the customer service person doesn't have to travel every time unless there is a hardware part to be changed. Not just that, I think in our industry, where we believe so much in touch relationship. When I say touch relationship, you have to be in front of your customers. You need to shake their hands. You need to hug them to sort of say, hey, listen, I love you, right? But that is not necessary anymore. We've actually done deals remotely, done demonstrations remotely. And the advantage is that I don't need to have an application specialist, let's say, from our own country, from that same town, to be in front of the customer, showing them how these things work. I could have somebody in Eindhoven, I could have somebody in the US, okay, as long as time, zones permit and everything. But you can have the best person show you and talk to you about the images that you see in front of your console. So I think my summary is that this pandemic, this COVID times, have actually accelerated the pace of innovation and of acceptance of some of these things. Okay.
Yes, completely agree. Kailash, what about you? What do you think about this?
So the panelists have really brought home a lot of key points already. I have a perspective which will touch some of these points and slightly maybe go beyond that also. The COVID has also brought into front the fragility of the operations of our healthcare providers, that specifically in terms of their P&L and other costs that they incur. So from that perspective, if we see, then the post-COVID, the theme would be do more with the less. And that I know is a cliche, but that will come to play from multiple technology angles. And those technologies which will be able to address this doing more with less would be the winner of the post-COVID scenarios. And the adjuvant to that would be, the way I see it, there is a strong possibility of Uberization of a lot of latent supplies or idle supplies that we have. Post-COVID, that may also come into front and start playing itself. For example, in the hospital beds, if it is in the hospital beds, or some people sitting in the audience here could think of how even medical assets can be sort of Uberized through aggregation, all those things. And third part is the human resources, the aggregation of that. And just to make a point there, in New York, we are currently in a project where we are doing exactly that. That how do we there's a demand supply of ultrasound techs, then how we strike a balance of this demand supply, this supply to reach where the demand is by by acting as an aggregator for ultrasound techs. So that would be the interesting angle which is going on and which could speed up. Another thing is Ashutosh and Rohit has also touched upon that doing things remotely, and whether it is on the providing care environment by EICU or through home care or whatever, it will not stop there. There are opportunities to take it to therapeutic areas by surgery or by, for example, doing a cath lab procedures remotely over a long distance, so that not only the expertise is available, but the travel and all other associated issues are avoided. Like, for example, Dr. Tejas Patel in Ahmedabad, they did a cath lab catheterization procedures over a long distance, sitting from Ahmedabad and doing it in Gandhidham in Kutch, I suppose. So those technologies are going to be even more, let's say, prominent. And the third area of the same, or one more area of the same remote topic would be, and this is where I bring in my, let's say, what we are doing here, is teleradiology, telemedicine, all those things are given. But can we take it to the next level that of doing a telescanning, which is unheard of so far? Let's say, if you have a centralized facility where highly competent technologists are sitting, and they can remotely drive multiple CTs and MRs at a different location and give a very quality images, because that forms the basis of for the radiologist to sort of report. So these are this is just an example, but the point is that this is a pointer towards what all possibilities are there, and how it will shape the future post-COVID. Thank you so much.
Well, thanks a lot for talking about lots of new technologies, the entire team. Next question I have for everyone is, how can medtech players balance compliance and innovation in medical device industry? And we know that anytime, and Ashutosh had kind of touched upon this point, and I've worked with GE in my previous life. So you have innovation driving at one time, and you have compliance. Sometimes they don't go together. Okay, so but they have to go together, especially in our medical device industry, because compliance is the key. We cannot risk patients. So Rohit, what's your thought on this?
Yeah, I mean, compliance is quite a broad-based word there, right? I mean, compliance to the legal laws, compliance to medical processes, compliance to quality, all kinds of things, right? So we need to choose what we're talking about. Now, India is quite a different kind of a country compared with what the Western world is, okay? So in these reimbursed kind of countries, when they talk about technology, medical technology, it goes hand in hand with outcome itself, right? Mm-hmm. So the cost of the technology that comes out there and the innovation is all directed towards how do you reduce the payer's cost, okay, over the lifetime of the patient. So health economics makes a very important argument in those types of settings. Whereas in India, that is not the case. Okay, if you look at, then maybe this is a controversial thing I'm touching on, but Ayushman Bharat, all the hospitals and the healthcare delivery setups have been saying, hey, is this reimbursement good enough for me to provide the quality outcome that is needed by the patient. I mean, can you treat two different patients differently, saying, hey, I've had a trauma, one person walks after the procedure, walks absolutely straight, no problem, the other person has a bit of a limp. And the argument is, hey, but at least, that person walks with a limp. The alternative was that they don't walk at all. So it is, in my mind, not a very simple question to answer, right? And this has been from the time that we had all these government sort of insurance schemes like RSBY. RSBY started with, I believe, a 30,000 rupee cover, for the entire patient family, everybody under poverty line. So, and people questioned at that time, hey, what really can you do with that? It was a beginning. It is a start. So compliance, yes, you can sort of say, or like I've heard in the company that I am in and before, that there is nothing such as 99.9% compliance. It's 100%, right? It's yes or no. It's black and white.
Yeah.
Yes, it is. Yes, it is. Once you choose what the objective is, once you choose what the trade-offs are, and I'm sorry, I'm giving you a very philosophical answer, Sanjay, because there isn't a very clean answer there. When you are making things like MRI machines and CT machines, you make them at the same cost and you make them at one place in the world and you make them for the world. But as Dr. Mahajan will also tell you, the cost of a CT scan in the US might be, I don't know, $1,000, whereas over here it can be as low as even $50, right? And for the same machine. Now, how do you manage in those settings? What role does diagnosis play? What role, does the quality of the outcome play? What role does financing play? I think once you get those things right, once you get your priorities right, then comes the role of compliance in ensuring that people get what has been decided, upfront before, right? So I don't know if that helps. Sorry, slightly philosophical answer.
It does. It does.
Sanjay, if I may just add a little word.
Please.
We need some innovative solution to pricing that is done for various government schemes, because no quality institution actually wants to take it up. And especially as the number of insured under those schemes increase, if you take something which is not giving you any profit, or even if you're making some loss, you can do 10%, 15% out of your whole patient base in a hospital or in a diagnostic center. The moment that goes to 25, 30 or 50%, you just can't do it. You will shut down. And that's where I wish that the industry, the government, the providers, they would all get together and do some very nice, correct costing of various procedures, because we don't know what it costs to do a surgery in a government hospital. We, even in a private hospital, it is very tough to know the cost. And that is where the distrust comes, because in a government hospital, it's all free for the patient. Of course, the taxpayer is paying for it. And so he says, or maybe it's a minuscule thing, something for 2,000 rupees. And outside, when he goes to a private party, it's 10,000 rupees. And he says you're charging five times the amount. Whereas it just may even be costing more in the government institution. We just don't know. So this is where, if we have to actually, if the country has to go to a socialistic kind of healthcare model where everyone is insured and those who can't afford are insured by the government, we need to know our costs. And once those costs are agreed upon, then you can say 10, 20, 25% profit, whatever it may be. And then it's how good you are at doing your job. And that's where things will come in. So I really wish through this program, because there are hundreds of people watching this, that at least a very objective costing exercise is done for procedures. In Ayushman Bharat, as Rohit mentioned, there are 1,390 procedures and treatments. And we believe that the costing exercise was really not done. These were figures which were taken from somewhere, maybe in some scheme or the other, and they were extrapolated here. So I really wish this program culminates in someone taking up this very, very important issue. Because if healthcare, and especially if quality healthcare, is to survive in this country, and do remember 70% or more of healthcare is in the private sector, and private sector doesn't have limitless funds to push in as what the government has. He has to, the sector has to get it out of the system, and if you don't have it, then you will slowly die, and that should not happen.
Thanks, Dr. Mahajan. I think we have rights to know how the government has done the costing, because everybody, and I have heard this in multiple panels about the costing on Ayushman Bharat, they might have whatever logic they have used. It seems for other people that is not working out. So there should be some transparency for us to understand.
Sanjay,
Yeah, Kailash.
It's also the same cost for public and private. So in a government hospital, you get something done where it's already funded. You pay the same as what the private sector is expected to do, which is also something which is unusual. Sorry, Kailash.
Yeah.
Sanjay, if you give me a 1 minute, even though it's not on the topic of the question that came up, but since Dr. Mahajan made this very interesting remark about costing, I just cannot help myself to comment on that. Last week there was one more virtual seminar like this, and the topic came up, and then the idea, Dr. Mahajan, which was mooted, was why can't healthcare have a CRISIL type of organization, which is independent of government, independent of the industry, independent of healthcare providers, whose neutrality is established, and it would be a healthcare economics and outcomes related organization. Who would be the right organization to conduct such studies, which can be sort of bought in by the various stakeholders? Because right now what happens is CII, FICCI, they present their own way of costing, and also it leaves out a big chain of big spectrum of other type of providers who are not part of one or other associations or calculations or whatever. So interesting that you brought it up. I thought I would just quickly share, and then
it's a very
sorry,
good
Sanjay,
idea.
not
It's
the question, but
transparent, open, and fair. It's a very good idea.
So thanks everybody. So let's get back to where we were. And Dr. Mahajan, you and your team have worked a lot on AI ML. I've seen quite a few articles. So how can new age technologies like AI ML, IoT, VR, medtech, it can drive medtech innovation to address pre-COVID and post-COVID healthcare needs? So I'll start with you.
We have been working for the last 2.5 years or so in the field of AI, especially as related to imaging and radiology. And we've worked on developing our own algorithms to begin with, to learn what's going on. And now we are focusing more on developing a platform which can house the algorithm, do testing, validation, and then can also be used for deployment. And I think it's a very, very exciting field. It is a field which, if it comes to a level, AI is not just about diagnosis alone. There are various aspects to it. And first is, a patient has to make a booking. There are AI algorithms today available which are very robust, which can tell you that out of the 100 booked patients, which are the ones who are not going to show up. Many times we book patients for the third day because we say we are booked today, we are booked tomorrow. So you come day after, and when patients don't show up, you're sitting free and your machine is lying empty. So there are then for getting the images themselves, this AI is used at the back end within the software for enhancing image quality, reconstruction, and things like that. Third, you have is once the image is obtained, then to do the measurements, to count the number of lesions, to point out the number of lesions. It's very tedious for a radiologist to measure volumes or look at sizes. AI is being used across the board now and is very capable of doing these measurements so that the radiologist can do other things. And the holy grail is actually that point where the computer and the AI algorithm will make the diagnosis, which is something, which is the aspiration, where it may actually replace the radiologist. That may not happen, but one thing will certainly happen, that a radiologist who uses AI will definitely replace the radiologist who does not use AI, because AI will enhance your capabilities. It'll make a good radiologist better, and a fantastic radiologist great, and an average radiologist good. And also, it'll accelerate, it'll increase throughput. If I'm able to report 20 MRIs today, with AI, I may be able to report 50, and so on. It will also make me more accurate, because it'll point out, it'll do the exact measurements very, very well repeatedly. So I think AI has a great, great potential in the field of radiology, of course, dermatology, ophthalmology, cardiology. Wherever there is digital data, that is, the surefire way of doing it. But with telemedicine coming in, I'm sure this is also where AI is going to come in, and maybe just a nurse practitioner with AI tool with a side may be able to prescribe as good as a good doctor. Already for dermatological lesions, skin lesions, AI has shown that it's better than the best single dermatologist, and as good as 20 of them put together. So it's exciting days, but the challenge really has been its acceptance in day-to-day clinical use. And once that challenge is overcome, then the world is open. And even a 1, 2, 3 member team sitting in their homes or in their garages will provide the solution. It doesn't need to be huge companies. Thank you.
So might be that our human thinking that, hey, if machine does one error, that is not okay, but if human does 5 errors, that's okay. So that might be a hindrance, I personally believe. Rohit, what do you think about this?
No, I think artificial intelligence, like Dr. Mahajan said, I think has got, and I'm just going to echo a couple of things at least that Dr. Mahajan said. It is definitely here to stay. Wherever you have digital and you have data, where you have an opportunity to look at all that data and analyze that, I think you are going to, and there is just millions of applications where you see that you can benefit from that. And the second one that I want to echo before I even say anything about what we're doing here at Philips is like he said, tomorrow a radiologist who doesn't use AI versus a radiologist who uses AI. Definitely the radiologist who uses AI will be more preferred tomorrow. And a very common thing for us to digest then in our lives is I don't know if you use Microsoft Excel, right? Excel spreadsheets. Now today, accountants, business managers, financial people who do not use Excel can definitely not, we can't even imagine those people today, right? So this is, it is a tool that is always present with us, and we can't do without that tool. If you're in business, finance, whatever. And same is with AI. Okay, tomorrow the world is going to metamorphose into an area where without AI you're not going to be able to be effective. And if you have to get the best out, if you have to get the best out of your machines, out of your radiologists, AI is the tool. Let me give you an example. Let me give you 2 examples from how we are using it along with the machine. Again, Dr. Mahajan mentioned that it could be how the machine is capturing images versus machine is captured images. How do I actually annotate those images? How do I sort of read those images? All that is at the radiologist's end. But the end at which we are, where the machine gets made, we got things like, compressed sense. And again, Dr. Mahajan knows about that. For an MRI, you can do probably 40 or 45 patients in a day, not more than that. If you have to get quality MRIs first time right and good enough to for the doctor to give a prognosis. But that's the trade-off. The more time I spend, the better quality I get. Now, compressed science is using artificial intelligence to say, hey, listen, you know what? I could reduce the time and yet get the same outcome. Or I could keep the same time and get a better quality outcome of the image. And that's what AI does. It knows, it figures out which anatomy you're at, what are you actually scanning, and is able to maximize its resources towards just finding out about that anatomy. We also have a lot of human intervention in some of our applications where, hey, when you're in there in a CT, maybe in an MRI, and the technician outside says, okay, hold your breath, okay, or do this or do that, or given those types of instructions, you probably don't need to give those instructions anymore. We have something called Vital Eye, which is just a plain and simple infrared camera, which is able to judge your body movements, able to look at the way your diaphragm is moving, and is able to tell whether you're breathing, you're not, how does it synchronize. You can even look at and get SpO2 from the color of your skin and the variation of your skin, and thereby tell when there is a systolic and when there's a diastolic stroke of your heart, right? So gone are the days when you're going to have errors because there's manual instructions being given, right? So AI is going to be more effective, more efficient, more accurate, and is hence going to give much, much better outcomes. Definitely the scene for tomorrow. Okay.
Well, looking forward to the smart world. Kailash, what about you? What do you think about this?
It's very interesting to see that already we are infatuated, or let's say we are so overawed by the AI, but we need to appreciate that AI is right now only in its infancy. It is going to grow phenomenally, and that reminds me of the interesting book, people would have read it probably, the Dan Brown's Origins, where the technology and human become conjoined, almost conjoined. So we are definitely moving towards those areas with such a strong rush for digitalization that is happening. Everything is getting digitalized, and that's getting more data. And to make those sense of the data, we need solutions like AI to hold it, to drive it. I would take the cue from Dr. Mahajan's statements on radiology, AI in radiology, and the, the, the significant challenge with which the radiology community, radiologists, see that as the equipment are getting better and better, they are throwing up larger and larger number of slices, whether it is CT, MR, or ultrasound, or whatever. You have so much of data which needs to be now seen through, and that puts a stress on the radiologist time, and that's where the time reduced. If a radiologist time to analyze a report or see an image is reduced by 50%, there's a 17% increase in error rates in the reporting. So this is the severe, let's say, challenge we are already coming to, and we will be seeing it more and more because radiologists are fewer, and the patient exams are increasing at a totally divergent lines. So here the solution, I just elaborate one small topic here. The solution that we tested a AI algorithm on a chest CT. We call it as an AI RAD companion, and it was used to do a retrospective analysis of at a particular site. On 86% of the cases, it agreed with the findings of the reporting which was done previously. But in 14% of the cases, it found new clinical findings, and there were significant clinical findings which could impact the outcomes or the cost of care. So this is something that is possible with AI. And of course, from Siemens side, we are working on this type of AI. We are working on AI in the oncology care pathway, so that there's again a very profusion of clinical materials, clinical articles, which a doctor needs to go through. If he just devotes the whole time, morning to evening, in reading the articles which are coming out, it would take him months and months, year to keep him updated on what's happening. This is impossible. What are the latest things which are happening? So that's where also AI can come in, and this is what is ongoing with us right now, on taking all this data, going through the new recent guidelines in oncology and bringing the diagnostic information, lab or imaging otherwise, and putting the patient on a right care pathway. So
Thanks, Kailash.
all said and done, this undoubtedly this is the future. Yeah.
Thanks, Kailash. I see Anjan here for Anjan. Can you hear us? Unfortunately, we are not able to hear him. So there are a couple of questions from audience, and since we are running out of time, although those questions are not directly related to this panel, but let's still go ahead with those. We were talking about pricing. So one of the audience asks, Dr. Bhaya asks, does it sound logical for government to fix scale of costs for diagnostics and show discounts for the same when provided within government-supported facilities? This would help reduce the gross misunderstanding in patients' minds. Dr. Mahajan, what's your take on that?
Yeah, this is great. You know what I understand from what Dr. Bhaya has said is that suppose right now the government charges 2,000 rupees for a scan, but actual price is 5,000, and that is what the objective cost is. Then they should say 5,000 and say we are subsidizing by 3,000, so that the person knows this subsidy has come from the government side. So it's an open, transparent way. And when he goes outside and someone charges 5,000, then he doesn't feel that I'm being overcharged, because what he has said is, I think, a great idea. And because the subsidy part, which the government or the taxpayers are doing, that currently is opaque. It's just that they say this scan is done outside for 7,000, but in a government hospital it's done for 3,500. So why are you charging double? Whereas that 3,500 or 2,000, 3,000, whatever the balance may be, is actually being paid for by the taxpayer. So it's a great idea.
Thanks. And there was another question about status of vaccine from Dr. Anand Premrajan from VIT University, Tamil Nadu. Yesterday, Dr. Bhargava from ICMR, he has talked about this. But if any of you know later updates on that, could you please share?
See, I can tell you that there are 3 vaccine candidates which are very actively, undergoing trials. One of them already has entered phase 3 trials. And as per what the ICMR has said, and also the Honorable Health Minister, Dr. Harshvardhan, has said, that we can, this is all optimistic angle. We can expect that a vaccine may get available for use in January 2021. That is about 3.5, 4 months from now. But that is again in inverted commas, and also not everyone is going to get it. It will actually depend. They will have to make some kind of a priority list, and probably the healthcare workers, maybe the army men, other people would get priority over the general population. And then it may, even if we are able to manufacture fast enough for our whole country, it may take, even if everything goes well, may take 2 years for everyone to be vaccinated. So this is, but the vaccine candidates are doing fairly well, and we are quite hopeful.
Thanks. So I think we are at the end of our hour. Any parting thoughts? Quick 10 seconds.
Sanjay, am I audible now at last?
Yes, Dada.
Yes, you are, sir.
I'm very sorry, but I just wanted to make a point. There were,
sure.
Two points. One is, I think you witnessed the example I went through in the last 60 minutes the challenges of technology, even, in terms of innovation versus compliance, we discussed that. Secondly, I think last week there was a great example in the country for our nation when the Tatas announced the CRISPR technology for COVID testing, which is, a step above RT-PCR in various ways. So I think there is a lot of things going on. And the other point I wanted to quickly mention before ending is, I saw a Microsoft ad which talks about resilience using technology and innovation, I think we all need to be resilient using it. Once again, I apologize that technology let me down. Sanjay, well done. Thank you for taking over. That's all.
Thanks a lot for everyone for a wonderful session. We did have some technology glitches, but still, I think I learned a lot. It was wonderful interacting with you all again. Looking forward to more interactions. And thanks a lot to the Voice of Healthcare team for organizing this event for us, where many people could come and share their views. So thanks, everyone.
Thank you, everyone. A lot of
you.
learning. Thank you.
Bye-bye.
Thank you, Rohit. Thank you, Dr. Mahajan.
Thanks a lot.
Thank you, Sanjay.
Thank you. Bye-bye. Thank you, Sanjay. Thank you, Dada.
Bye-bye.